Next time on the polls.
Now we are fishing. All right. Good afternoon, or I'll say howdy, everyone, as I am joining you today from the great state of Texas. This is my second or third time in Texas this year. I am currently here representing the KU ADRC and the Alzheimer's Therapeutic Research Institute for the inaugural Black Down Syndrome Family Reunion Conference. And I am going to do a presentation tomorrow about the relationship between Down syndrome and Alzheimer's disease. So I'm really going to pay a lot of attention today to Dr. Burns. I mean, I would have anyway, but especially in case I can borrow some of his wisdom to tell the folks tomorrow at the conference. So I'm happy to be here, always happy to be with you on the webinar. Thank you for muting yourselves. And feel free to use closed caption as you need to. There's a button at the bottom of your screen that says show caption. Use the chat if you have questions or comments, and I'll watch that while Dr. Burns presents. And we are recording, and this recording will be available later this afternoon to watch. So with that said, I'm always happy to have our co-director, Dr. Jeffrey Burns from the KU ADRC, to give us some updates for 2025 as we come to almost the last month of 2025. We'll hear directly from Dr. Burns about some things we've learned over the last year and the direction we're going in as we move into 2026. And so, of course, Dr. Burns is our co-director. He is the Edward H. Hashinger Professor of Medicine at KU. He started the KU Clinical Research Program in 2004, so 21 years, almost 22 years, doing this great work. Dr. Burns has a bachelor's degree in English, which is very cool, and in Japanese, which is probably cooler, from the University of Notre Dame. Got his medical degree, of course, from KU, neurology residency at University of Virginia, and postdoc fellowship at Washington University in St. Louis. And of course, we are super happy to have Dr. Burns with us at KU now. With that, you are in for some great information and insight. Dr. Burns, thank you for being with us today.
Okay, thank you, Kelly G, and thanks everybody for being here. Great to see everyone, see you virtually. I am sharing my slide, right? You'll tell me if I'm not, but so great. It's great to be here and to be able to kind of give an quick overview of where we are, but really more focused on where we're going. It's a really important time, I think, in the history of this fight against Alzheimer's disease and moving towards an era of brain health, where we're thinking about not disease, but thinking about how do we prevent and prevent Alzheimer's disease and maintain brain health across a full lifespan. So that's where we're headed. So I'll give you an overview of that. And you're all here probably because you already know this, that Alzheimer's is a huge problem. 7 million Americans have it now. It's growing. It's growing because it's so common in older adults. So 1 in 3 people over the age of 85 have Alzheimer's is the estimate. 1 out of 3, which is really amazing. And that's the fastest growing segment of the population. So this is what drives us every day to develop new treatments and ways to prevent Alzheimer's disease. So we've got to prevent it because this is only growing and it's a huge and difficult problem. So what's happening right now is really, for me, it's been an amazing couple of years and I'm super excited about the future. And this kind of tells the story and hopefully you'll see why I'm so excited. Because we really have achieved more in the last couple of years than really in the whole history of Alzheimer's research, beginning back in 1905 when Dr. Alzheimer described the first case now known to have Alzheimer's, but it was in really 2003 when the last drug was approved. I remember walking the halls in the early days of my Alzheimer's fellowship at WashU when memantine was approved in 2003. And donepezil had been approved 7 years earlier. And these are drugs that really you can kind of think of them like a strong cup of coffee and not much more. They do have an impact. They're important. So I don't want to downplay them, but they're pretty limited and pretty modest in their benefits. And over the next 18 years, essentially every trial that was done failed. And that's what, so I got here in 2004, back in Kansas City in 2004. I grew up here, moved back. My wife grew up here. We moved back. And really, my goal was to start a program and grow it and see how things turned out. And super excited about where things are today. But that was tough 18 years. And it was in 2021 when the first of the anti-amyloid drugs was partially approved. And then there was a lot of controversy. And it was really 2023 when Leqembi was approved, and then Kisunla shortly thereafter, or a year or two thereafter, 2020. Was it this year? Um, Time's moving fast, if so. But new drugs. So 18 years, really nothing. Really 20 years, really nothing. And then now we have these new drugs that go after amyloid. And then so that's a key and major step forward. Not a cure, but a very important step forward. The other really important step forward that's happening right now, literally in real time right now, is new blood tests to help us make a diagnosis of Alzheimer's disease. Both of these things, we worked on that entire 20 years where I've 20, 21 years that I've been here. We've been working on these things. We've tested the anti-amyloid drugs for about 15 years. And then we've been working in one way or another on these blood measures or biomarkers to detect the presence of changes related to Alzheimer's in the brain for the whole time as well. And this is where we are right now, is rolling these things out and figuring out how do we get them to the right patients, and they're having an impact if we get them to the right patients at the right time. But it's really hard to do. And we're looking ahead to the future too. We're learning right now, do these types of drugs prevent Alzheimer's? We'll learn that over the next couple of years. We've been testing that idea for a good 10 years. And we have all kinds, as I'll come back to this, all kinds of trials on all kinds of different drugs going after Alzheimer's from all kinds of different approaches and angles. And that's exactly what we need. And so this is the trajectory we're on. We worked really hard without a lot of movement forward, though we were learning every step of the way until just recently when we're starting to really have some success and move some things forward that are impacting patients. And that's our goal, is to impact patients. Um, so I'm going to take a step back. These are two key concepts that really guide everything we do. The first is the changes of Alzheimer's start in the brain up to 20 years before memory loss is seen. So we can detect, at least on the research side, we're detecting the changes of Alzheimer's up to 20 years before the onset of symptoms. So that is really important because that's a window of opportunity. We can't yet do much about it, but it is a window of opportunity, and we're doing lots of research in that area to try to understand, can we prevent it or deflect it or slow it? And then the other thing is on the right is that it doesn't take a whole lot. If we can actually postpone memory changes a few years, if somebody's going to get Alzheimer's or going to get dementia or memory change, if we can postpone that by doing things like lifestyle or even drugs, by 5 years, we can cut the incidence of Alzheimer's in half. And so, small things can add up, things like exercise, things like diet. And if we have drugs that have an even bigger impact, we can have a huge impact on the incidence of Alzheimer's across the whole population. And so little things can add up in a big way, fast when we're thinking about the population. So two important ideas. And the other important idea now, which is even, today more than ever, as every moment counts, these new drugs that we have work best early. The earlier we start them, the better, on average, people do. So early intervention matters in terms of extending quality years and better control over what's happening in the future, and actually getting to the new breakthroughs that we hope are coming. So every moment counts. And we've always thought early diagnosis was important, for lots of reasons. But now we have an additional reason, which is we want to get these drugs to the right people early. So very important. So why us? Why are we doing all this work? Why are we driven to do all this work? Why do we have this big team that we've built over 20 years doing all this work? And really, it's, we're dedicated to this. It's personal for many of us, and we want to improve the lives of patients who are dealing with this disease. And we are one of the 35 nationally designated Alzheimer's disease research centers. So we have a big grant that we won beginning in 2011, and we have to re-win it every 5 years. We just recently submitted our application in September. It took a year to write, and it's about 900 pages to sort of win our grant. But we're part of this club. These are the states in blue that are part of the Alzheimer's Disease Research Center network. We all work together. We all compete in a way too. But we're all working together for one thing, which is improve the lives of people who are dealing with Alzheimer's disease by treating it better with drugs and lifestyle interventions, but more importantly, preventing it. And so we're all built to and organized around this mission of driving towards a cure and a prevention for Alzheimer's disease, a prevention strategy for Alzheimer's disease. And so we all work together across that network of 35 sites. And we also compete a little bit. Our theme, which is different than everybody else, is metabolism. What do I mean by this? Well, mitochondria at the most basic level, diet and exercise sort of at the big picture level. These are things that influence metabolism. Diabetes is of interest to us as well. And so we really focus in on this, and we're thinking, how do we develop new therapies based around the idea that metabolism at the cellular level may be driving a lot of these problems. So a lot of our site, that's Dr. Swerdlow, you guys know. I'm sure he's an internationally known scientist focused on mitochondria and metabolism, and his ideas are what are driving a lot of the science that we're doing. And so when I say we compete on some level, we want to differentiate ourselves and lead the field in areas like this, and we have been for a long time. So we do that really well. The other thing we're doing well is, I think we're thinking ahead and we're preparing for what we see as a tsunami of innovation that's coming. This figure on the right, every dot represents a clinical trial that's ongoing right now, 182 of them, and they're testing all kinds of different approaches. All the different colors of each dot represents a different approach. 10 years ago, there were only a couple things that we were testing, approaches we were testing, amyloid being the main one. Now there's many, and which is for me very hopeful that we're attacking this from a lot of different angles, because that's what it's going to take to prevent it. The other exciting thing is we have prevention trials that are well underway, where we're 5 years into doing these prevention trials. And in a couple of years, it's still going to be a couple of years, 2-3 years, before we know if using these new drugs can be an approach to prevent or stop somebody from developing the memory problems. Lots of new drugs. It's only going to take a couple of these drugs on this figure on the right to be effective, to really change the world, continue to change the world in terms of how we treat Alzheimer's. And so we're hopeful that a couple of these are going to be successful. And then we're also hopeful that these prevention approaches that we've worked for a good decade on are going to work as well. So exciting time. The other thing that's happening and that we're leading the way on is, how do we deliver this care better? We have these new tools. They're not being used very well if you look across the country yet. And the reason why is they're hard to implement. It's just hard to get it done. And so we are really leading the way. And how do we get it done? How do we develop new models of care? How do we use primary care? How do we use memory care? How do we grow memory care, even though there's not more neurologists out there? And we've published a paper on how we developed a treatment clinic approach that has helped us deliver the new drugs to about 275 people so far, which is a lot. If you look nationally, that's a lot. We're one of the leading centers in finding the right patients for these drugs. And the other thing we're working hard on and preparing for is AI and technology can really help us with dementia detection and dementia diagnosis, and making sure that we can create new access points all over the state, for instance, and I'll come back to this. So we're trying to figure out, how can we use AI as a tool to really help us accelerate and increase access to cutting edge diagnosis and cutting edge care. And I think there's ways we can do it. So, but here's where we are today. This is kind of the unfortunate fact, and it's a national problem. And it's that it's still a very long and hard road to get a diagnosis. If somebody's having memory problems, it's still hard to get a diagnosis. And the way it tends to work is they might bring it up with their primary care doc, or their primary care doc might ask, hopefully they ask, and detect an issue. They'll usually follow it up 6 months later, check on it. And if issues are persisting, then they'll start an evaluation, which takes time. MRI, maybe get labs, months more go by. They refer to neurology. You refer to basically any neurologist in the country right now, and it's on average probably 6 month wait. That neurologist hopefully is an expert in dementia, but not all are. They'll probably order testing, follow up 6 months later, and eventually confirm an Alzheimer's diagnosis and start the meds. Will they think about the new drugs? Maybe. They're probably not an expert in that. There's not many. And so, you may or may not get access to the new drugs if you follow this path. And this is the typical path. And that's the reality. And this is not a Kansas City problem. Actually, I think we're probably better off in Kansas City and the state of Kansas if you get to us in Kansas City than anywhere else. But it's still a long wait, and it's still a long road and hard to get that diagnosis. So, is the answer just developing more neurologists? We don't think that is, a reality. In the last 10 years, there's only been 600 more neurologists. And Kansas is a neurology desert. There's about 200 neurologists. Most of them are in the Kansas City metro area. We think the furthest west is Dr. Davis in Salina. Salina is not that far away from us. So it's a big state and we have a lot of needs. And we can't just say we're going to add more neurologists. That's not realistic. So what are we doing? This is what we're doing, sort of from a big picture, to really rethink how we deliver better care and make it more accessible to everyone who deserves it. And we're thinking about it at a system level. When I say that, at the whole University of Kansas health system level, there's 120 plus primary care docs. There's a neurology department. We now have multiple campuses. And so how do we think about brain health care at the system level? If you zoom in on what it takes to make a diagnosis, so the workflow for a clinician, what does it take to make a diagnosis? There's a certain step of, a sequence of steps that we follow to get the right information to make a diagnosis. We're rethinking that and how we can get that done. And then we're thinking, all right, if you combine those ideas, and I'm going to walk you through this, how do we get it out across the state? And that's the big idea. We want to take what we're learning and use everything we've got and then build hubs out across the state so that everybody who, wants and deserves a cutting edge diagnosis can get it. And so here, I'm going to zoom in on the health system effort. It's a little busy, but what we've done over the last 2 years is a health system wide effort where we've implemented the new blood measures before everybody else. Before the FDA approval, for 6 months, we've had the blood measures going here across our health system. We've had 1,400 blood tests ordered by over 100 doctors or clinicians, I should say, across the health system. And we're leveraging the technology of things like our electronic health record to create workflows and create order sets so that primary care can do all the right things. We can sort of tee it up so that they can do all the right things easier. And then we've rethought our memory clinic. How do we don't have necessarily anymore a single door into the memory clinic. We actually have multiple doors in. If you want, treatment, you want to know if you're eligible for the treatment, we can get you in quickly. But we answer that one single question versus other pathways. So we really rethought in a way that no one else across the country that I know of is rethinking how to do memory care. And then we're working more collaboratively with primary care. We're working in a way where they're really smart and good clinicians, but they don't have everything we've got. So how can we support them in a more efficient way so that we together can do the job for the patient, the best job for the patient. And so we call this our Brain Health Care Accelerator, supported by the Davos Alzheimer's Collaborative, and Gates Ventures has been helping with the data platform as well. So getting some real big national attention for what we're doing at the health system level, and working in primary care. And I should mention, Jennifer Woodward in family medicine has been a key partner in leading this sort of institutional change across our health system to try to get better at how we deliver care. Now, I mentioned zooming in on the workflow. These are the features that we need to get done, or the steps that we need to make a diagnosis. And at their most, elemental level, we need good data and good information on what's been happening to the patient. So the clinical interview is a key step, and doing it right is important. And so we've worked on scripting that and really making sure we're getting all the right information through an interview. Cognitive testing is important. So doing some pencil and paper tests. In this case, we're moving towards a digital cognitive test that can be done basically anywhere without a lot of expertise, where we can deliver it on a tablet to the patient, ideally in the clinic. Draw blood for the blood biomarkers, and then get an MRI scan to look and make sure there's no tumor or stroke or any other obvious problems for why a patient's having the issues they're having. And those are the four features that we really end up needing on every patient: is a brain scan, blood measures now, those are new, cognitive testing, and then all the information that we need to gather around, who the patient is and what's been changing. And so if you break it down to this level, we think instead of it taking sometimes for people 2 years to get all this done, we can get it done in 2 hours. And we can use AI to actually sort of bundle it up, package it up, and deliver it to the clinician so that they have everything at their fingertips at the right when they need it, when they're seeing the patient. So this is something we are testing here in Kansas City, and beginning in hopefully a couple weeks out in Salina with Dr. Davis, where we're going to help him with his patients who are sitting on his wait list waiting to see him. We're going to put them through this protocol and then hand this information over to Dr. Davis to see, can we streamline the diagnosis and speed it up so that the right patients early on are getting the drug quicker and getting the care they need quicker. So now, with those two ideas, I want to just provide a little perspective. Dr. Davis is one person we're working very closely with, but we're working with a lot of others. This is our cognitive care network sites, where we have partnerships with various clinics across the state. Michelle Needens has been building, and her team of 10 social workers and nurses have been building this up over the last 8 years. And the reason we've been building it up is to provide better care and support for patients first, but to build for the future, which is now. To create this network so that we can begin to build and move out the new drugs and the new technologies as they come about. And so back to this idea of the statewide reach, so what are we doing? Well, we're testing here in Kansas City, the system level approach. We're testing the workflow level, improvements to speed the efficiencies and get this data that we need to make that diagnosis. We're moving it to Salina literally any day. We trained yesterday with the Salina folks at the School of Nursing who are helping us with this. And hopefully in the next week or two, we'll enroll our first patients to test this model. We know it's going to work one way or another. It's going to work. We have to refine it and better sort of package it as we go. But as we do that, then the goal is expand across the state with new PCP partners, leveraging our statewide network and other networks that exist, such as the Care Collaborative. So that's the plan. That's where we're going. That's where we're headed. And we think we can really have an impact and in a lot of different ways, really a transformational impact to really improve access to care for everyone. Not everybody has to come to Kansas City to get the optimal care that or diagnosis that they deserve. We can create a platform for the future of prevention and prevention drugs and prevention programs that we're working on the research side. We can advance brain health for all Kansans. This can also apply to any state. And we can use this platform also to continue to accelerate the research that we're doing. That's really fueling sort of the engine behind all these changes. So that's the vision. That's a little update and the vision for our future. And I will stop there, and we have 5 minutes for questions. So thank you, everybody.
Thank you, Dr. Burns. Yes, there's some really great questions in the chat. And I will just take the liberty of saying we'll get to as many as we can. And if we don't get to them all, I've copied them and pasted them into an email to myself, and I'll track down the answers. So with that said, we'll just kind of go in order. Dr. Burns, the first question is about at what point in the onset of Alzheimer's can the blood test detect it? And can it detect that 20-year pre-Alzheimer's window?
Okay, great. Thank you for asking that. And if I had another hour, that is the question that we, have been working on for a long time. And the answer is today we want to use that blood test when we know there's some memory changes, because we know the drugs work when we have somebody with memory changes and amyloid in their brain. The blood tests detect amyloid. We don't yet know. So that's we want to use those tests in people who we know have memory changes, is the short answer to your first question. The second question is, can the amyloid, can these blood tests detect the presence of amyloid 20 years before the window? The answer is yes. This is a much longer answer, but that's not that useful yet to know. It's going to be useful in the future, but it's not right now in terms of what do we do with that information? How actionable is that information? Many people have amyloid in their brain without memory problems. And if we follow them for 6 years, only about 10% will develop memory problems. 90% are doing fine 6 years later. So it's not the best predictor. And we don't want to get all worried about it, yet. So we got to get better measures. We got to get better risk assessment tools. And then, most importantly, we need better treatments. We need something we can do about it. That's all coming. And I think in a couple of years, it's going to change. But today, we only use the blood test on people who have memory problems. Okay.
All right. Next question is about amyloid plaques and whether the work at Vanderbilt, technically speaking, zapping them at Vanderbilt, and should a person go there to get that treatment?
Yeah, you know what? I don't know exactly what that treatment is. I know there's some light therapy and stuff like that. These new drugs kind of zap amyloid plaques now. If you're having memory issues, or memory slippage, memory change that's detectable, and a clinician thinks it's significant, I think if it's early, it's probably worth looking into it. If you're eligible for zapping the amyloid with the new drugs, then it's worth considering it. Now, there's a lot of pros and cons, and there's a lot of things to work through, which is why we started an anti-amyloid treatment clinic, because it's not the simplest decision to make, but it's worth looking into. Do you want to go do a research-based, zap it with some infrared therapy or things like that? I don't know, probably not. If it was right next door and if we were doing it and you were interested in doing it right here, you could, then great if you're interested in research. But consider it research. I'd consider it optional. But if you qualify for the new drug, I think that's something you want to make sure you're thinking it through. And if it's right for you, and it's not right for everybody, if it's right for you, then it's worth considering it.
All right, very good. Next question, and I'm especially going to listen to this one, is about whether the drug trials included anyone with Down syndrome, and if so, what were the results?
Yeah, great question. And the answer, not yet. These new drugs that go after amyloid, we're just gearing up to start testing them in Down syndrome. And it's important to test them in Down syndrome because there's some risk to them. One of them being hemorrhage, brain hemorrhage. And there's reasons to think that Down syndrome patients may be more vulnerable to that. So we got to test it carefully and show they work before we start prescribing them to Down syndrome patients. That's happening right now. And I'll say this, we're one of the top sites for Down syndrome research. Just in the last couple, Dr. Lauren Tomey, she's probably sure been on the webinar. Dr. Lauren Tomey joined up with us, and together we're working to build out a big Down syndrome research program. And we're part of the National Network of Down Syndrome Sites, ABCDS sites. There's 10 now in the country. We're the 10th, the 9th or the 10th. And have a whole lot going on. We have committed, for the long term to be part of this effort to prevent dementia and Down syndrome patients.
Very good. Okay, a popular question. When there's family history, is there an age to test before symptoms?
Yeah, so if there's a family history, then your risk is a little higher. And your risk of having amyloid in the brain is a little higher. Doesn't mean you're destined for it. For the vast majority of people, it just means your risk is a little higher. And I'd go back to my first answer about who to test with these blood tests. The answer is really if there's memory changes that are detectable and significant to a clinician, and at a memory center, for instance, um, then it's worth testing. It's not worth testing to gauge risk yet. So I would say don't test if you're not having memory issues. And you want to do it in the right context, with a workup, do the blood tests. But again, that's going to change. I think in 2 to 5 years, we're going to have risk assessments where we better answer this question.
Dr. Burns, this is Eldine up here at Smith
Hey,
Center.
Aldine.
And that was my question. And
Great.
because I have that family history and we have that. And I think it's that gives a positive time for me to my family, is that I've been promoting and pre-testing and getting done. But the guideline is when you have a problem.
That's the guideline now. And
okay.
It's so when we talk about screening, the right thing to do with screening is to look for the problems, the memory issues. It's not yet to do the blood test.
Yeah. Well,
but again, we're working. We want that future that everybody's asking about. Can we do it now? Can we do it now? And not yet. Really not
I'm
yet.
involved with one of those outstate at Smith Center at our Smith County Memorial Hospital. And I want to thank the KU Center for that support, because I think we're having Dr. Conad is having a good success with people coming in, and the visit from the caseworker and all of that. That's been very well received up here. So thank you for reaching out to rural, small town America.
All right. Yeah, that's our mission is everyone. And this is a big state, and we're the Kansas Alzheimer's Center. So yeah. So I've visited Smith Center, and that what a great clinic, what a great operation and facility there. It's really amazing.
Awesome. Dr. Burns, there are a few more questions. I just want to do a time check with you. Are you?
I'm okay. I'm okay.
Okay.
Yeah, can do a couple more minutes.
All right, wonderful. Next one I see then is, should folks who know they have a copy of the APOE4 gene get the blood test?
Yeah, again, same answer. Yeah. Yeah, same answer. I would say sort of be vigilant about memory changes, and that it's less probably the person with the E4 with the risk, and more is family noticing any changes, any significant changes. Are you having trouble on the job? Are you getting turned around when before you didn't? Are you having trouble with the taxes when before you didn't? So new changes like that, that's a good time to be thinking about getting tested.
Okay. Then we've got, how do we know if my wife's neurologist at KU is familiar with, I think, all of these tools you've been talking about? Got a diagnosis of my MCI with Lewy bodies more than 4 years ago. Sketchy treatment. Maybe it's FTD. How do we treat all this? Short-term memory.
Yeah.
How do we get a definitive diagnosis?
Okay. Well, yes. Thanks for the question. And yeah, sometimes it's a process. Even if you get all the things done like I just laid out, there are very complex cases that change over time and confuse even the experts. And this may be the case for this person's wife. But I think this blood test is new, so asking the neurologist about the blood test, it sounds like it would be an appropriate test for your wife. And so I would ask about it. And there's other things too. There's other tests that can be done to help sort through, is it frontotemporal dementia versus Alzheimer's? There's even a PET scan, an FDG PET scan can help us with that. And then there's actually a skin biopsy now that can help give some insight or good insight, I guess, into whether somebody has Lewy bodies. So there's a lot, and this stuff's new in the last 3 to 4 years. So it's evolved. The field's evolving.
Dr. Burns, that was my question, and we've gone through all of that: the skin test, the MRI, PET before that, and we still can't seem to get the definitive diagnosis. I understand it's a process. But we had not heard, and the neurologist had not brought up this blood test. So is there a name for that blood test?
Yeah. Well, I mean, yeah. So, and I actually, it's p-tau 217 based test. I avoid that because it's sounds for if you haven't heard it a lot, but it's p-tau, phospho-tau 217, or the Alzheimer's or amyloid blood test. And it's becoming, people are becoming more familiar with it every day. And it's something that can be ordered at KU. So I think it sounds like it'd be a good thing to get on your wife.
Very good. Okay, we've got next a question about the digital cognitive test. I think which one, or is there a
Which one?
certain name for it? Yeah.
Oh, good question. We're still evaluating, and there's expense and contracts and setup and all this. So we have held off on that when we're planning. There's a number of them that are available, and check back with me soon, I guess. That's Emily, but yeah. So we haven't done it yet. We're doing the quickest sort of easiest pencil and paper, which work well. That's what we do in the clinic right now. And then we're going to start experimenting with this digital. The idea here is, we have people upstairs who do great job of cog testing, but what about somebody who only sees somebody like this once a month? We could, deploy these digital cog tests and get really good data easily. So that's the idea, is sort of scale this out through digital cognitive testing. So it hadn't been a huge priority for us, but it's becoming one now.
Awesome. Okay. Let's see. I think the shortest answer maybe to about whether there are physicians in Wichita is probably, but I'll let you say so, Dr.
We're working with some there, and there's a big group there that we work a lot with, or clinically. On the research side, we're working with Dr. Byerly, he's in psychiatry, and they're on the Wichita KU campus. So yes, we haven't rolled this. We're going to roll this out more and more every day. Right now, we're just rolling it out in Salina, but we have plans for Wichita, hopefully, and Great Bend and beyond. Anyway, actually, we don't have sites yet. So if you are near a site who you think would be interested, we would be love to talk more.
Awesome. Okay. This one's really fascinating. How do you approach a professional who maybe handles sensitive information in healthcare or DoD, which I presume is Department of Defense, when diagnosed before memory changes occur?
Okay, great question. So the question is, this is sensitive. So let's go back to, we've been asked now this question 3 or 4 times, right? Of should we do testing before memory problems arise? And I've given you some reasons why we're not doing it yet. The one I haven't given you, and it is on the list, is it's sensitive information, and it could potentially be used against you. If you're 70 years old and super healthy and your brain's working great, but you have amyloid in your brain, and we put it in your medical chart, it's possible long-term care insurance would say, no, thanks, we're not going to cover you. So it is sensitive. And that's why we want to make sure we're testing the right patients. If somebody has memory problems that are documented, long-term care insurance probably isn't going to cover them. So adding that test to the chart doesn't, put them at a disadvantage. So another reason why we don't really want to test yet in that pre-clinical, when people are healthy stage. So good question, Jeremy.
Very good. All right. Next is a compliment, and make sure you'll see that one, Dr. Burns, is that you are spoken highly of by a KU physician.
Dr. Stolte, I think. Stolte. Yeah, so we've got a lot of great primary care docs, and they're very involved, which gives us a ton of hope for our plan to really bring primary care onto the front lines and work collaboratively with us. So thank you for the comment.
Very good. And then, this is an important one. They're all important, about whether research is affected by government funding.
Yes. Yeah, it's a rough time. It's a scary time, and and it's an uncertain time for us, and it's slowing us down. I think we're going to get through it. But if, there's some plans that and if the NIH, National Institutes of Health, gets cut in half, I don't think that will happen, but that's what the administration, wants to do right now. that would devastate us and devastate our efforts. So that is a huge threat. There are other threats that we're going to weather, and we're going to fight them, and we're going to be fine in the end. But yeah, it's a hard time, and it is affecting us. It's slowing us down, and it's taking away some of our the support we've accumulated over 20 years so that we could build what we're building. Things like this are hard to pay for. Kelly G is working. It's like, how do we're not seeing patients, we're not generating dollars that our health system uses to pay for stuff like this. We have to come up with it and create it, and that's what we've done over 20 years, and we're going to keep doing this. So yeah, but yeah, it's advocate for research, the importance of research as much as you can. So we need it.
Yes. Okay. A more specific definition of memory issues is the next.
Yeah. Great. Yeah. So yeah, and I know I've said that a number of times. When is there real memory slippage? When is there real memory change? That's hard, and I sort of intentionally didn't define that because it takes a little bit. But thanks for the question. And it's when there's something new going on that's slowing you down a little bit. Not forgetting your car keys or your glasses, misplacing them like you've always done, but having trouble losing them and needing help finding them, having trouble doing the taxes and I mentioned this earlier, when you didn't have trouble before, paying the bills when you didn't have trouble before. And if it's repeating conversations when that wasn't something that was characteristic of that person, telling the same stories over and over again when that wasn't something they did before. So when it's changed like that, that's when we are, the red flags go up and we get worried, even if it's mild. So, but it's real change, and it's persistent over time, not real, like it happens every once in a while when you're distracted or you're stressed, but it's persistent. So persistent, clinically significant cognitive change is what we're looking for.
Very good. Okay, let's see. I think we're kind of winding down, Dr. Burns. Some of the questions I think you've addressed, but I want to mention the question about if the person knows they have amyloid plaque and APOE4 and a family history, changing diet, exercising, losing weight, what else? Is it too late to just wait to have symptoms?
Although those are things to do, and those are good things to do. So I'd stay focused on those, treating those things, treating your cholesterol, treating your blood pressure, trying to lose weight. Maybe these new GLP-1 drugs, we think they may be helpful. And we'll find out in a few weeks, December 3rd or so. Novo Nordisk is releasing the results of a study that's been going on for 5 or 6 years of Ozempic. So, and then keeping an eye on symptoms, and if you develop symptoms, then these new drugs are something I think, to be aggressive about considering. So, but yeah, great question. To keep doing what you're doing. But yeah, those are the right things.
Okay, and then we've got a question about after the diagnosis, what's the typical follow-up schedule? How often, what frequency? And does the patient need to be proactive?
Yes, stay proactive. Do the same things: exercise, eat right, try to make little lifestyle changes. We think that's helpful. And then, it just depends on follow-up. There's no formula, but we like to see people every 6 months or so. Once they're on a stable trajectory, they're on the right drugs and doing okay. If there's turbulence, if there's behavior changes, there can be, mood and anxiety and sometimes agitation, then we need to see people more regularly. So it just depends. But and then if you get a clinician who's really involved and knows how to handle things, then seeing them is part of the process too.
All right, one more.
Okay.
And this is preventive drugs. How long will it take before neuroprotective drugs are available for those with high risk?
Yes, I would get. I mean, we don't know how long. I think they're coming. But the next big drug, which we'll find out in 2 to 3 years. So we got a little ways, is these two drugs, Kisunla and Leqembi. Both of them are being tested in patients who have normal memory but have amyloid in their brain. If we pull that amyloid out of the brain, does that reduce their risk? So within a couple years, we'll know if we should be targeting amyloid for removal in people without memory problems. That's probably the next big thing, big sort of milestone in the world of prevention. We're learning every day about exercise and diet, small, do it, modest benefits, small benefits that we think are real, important at a population level, important for an individual too, but they're not a cure. But going after amyloid early may hopefully has a even bigger impact, but we're going to find that out.
Okay. Oh, we got a couple more that snuck in. Low dose lithium and or olanzapine. Are those helpful?
Well, so low dose lithium is in the news right now a lot, and it's been around for a while. It's been studied. It's not clear if it helps, and it's not clear if it doesn't. So there's sort of unclear data from clinical trials saying that maybe, and then this recent report showed even more sort of evidence, sort of biological evidence that maybe it could be helpful, but we don't really know. We're not recommending it yet. It's still early. Not recommending it. And then olanzapine, does it help? It can help if people have behavior changes, agitation, hallucinations, things like that. Olanzapine, it can be helpful in that setting. Not really used to treat dementia or memory changes, but more to treat sort of the other problems that can be associated with memory changes. And Kelly, my question for
This
you.
is a commercial.
When is My Alliance for Brain Health coming out?
Next Monday, 7:00 Central Time. The next issue will be out, and I have very good news for all of you who hung in there. You got some great information from Dr. Burns, and we'll be back at it next Thursday with Dr. Swerdlow, who will join us to do some more research updates. So Dr. Burns set the bar pretty high for Dr. Swerdlow next week. I don't know if we'll warn him or not, but he'll be with us to give some more information. So join us next week at this time. I put a note, the commercial in the chat was, look at your newsletter because you can find out about our currently enrolling studies, including, I hope you noticed, that we have a new medication trial that's just started up. And it's the first one, I think, in a while that KU has had. So very exciting to think that we could be on the forefront of a new drug. So check your newsletter for that. Come back next Thursday at 2:00 with Dr. Swerdlow. And I appreciate you, Dr. Burns, for sharing your time and your information this afternoon and always.
Thank you, Kelly, for representing in Dallas at this big national event for Down syndrome and Alzheimer's.
Yes, very excited, and I'll bring some good information back to Kansas City. Everybody think good thoughts for the TSA. I'm hearing about flights being canceled, so I hope I get back.
Okay.
All right,
yep,
everyone.
Good luck.
Thanks
All right.
a lot.
Bye-bye, everybody. Thank you.
Bye-bye.